Hey guys, we're back. We made it. 24 hours. This is the 23rd. By the end of this one, we hit 24 hours and we're done. You will have gotten a chock full of foot and ankle sports, hopefully enough to keep you busy and to take care of your patients. To me, this is one of the most exciting sessions of the 24-hour period, which is why I wanted to have it at the end. Dr. Jesse Morse is a physician down in Miami, sports medicine, and he's going to talk about biologics and regenerative medicine. That's kind of where the future is going, especially with the athletes, where they are pushing the limits and stuff that works there kind of percolates its way into the public masses. So, Jesse, take it away. I do want to thank Amniox for sponsoring this event or this hour. Thanks.
Thank you very much, Dr. Parekh. So, yes, we are in Miami. We take care of a lot of professional athletes. This will not be specifically just for professional athletes. This is going to be a general overview of all the different biologics and regenerative medicine, different opportunities and different things that we have available. And then we will break down some cases and give you an idea of how they presented, what we chose to inject them with, and then how they ended up. So without further ado, Dr. Kosubevsky, please start us.
Thank you, Dr. Morse. So I'm going to open up this discussion by talking about what biologics and regeneratives are. I'll just give a brief overview of them before we go on into the cases.
Okay, so we'll start with 6, by the way. We'll kind of do an overview.
Okay. I'm just waiting for you to pull up the PowerPoint, Dr. Morse.
Oh, okay. Give me 1 second. It's on my screen. Can you see that or no?
Oh.
You should be able to share screen, Jesse.
I thought it was in there, but I guess not.
Okay, so while they're starting to get that pulled up, so we're going to talk about what is prolotherapy. Prolotherapy is basically the basis of everything we do. It's a regenerative therapy. The name prolotherapy, it breaks down to the keyword of prolo is as in proliferation. And it works on stimulating the body's own healing factors to create tissue regeneration and stabilization. So it's been around. The first official book was written about 1956 by a couple of doctors named Doctors Hackett and Hemwall, where they presented all of their animal research studies and created the first solid manual of prolotherapy. And then prolotherapy has become a very general descriptor of a whole bunch of different therapies, including what is effectively prolotherapy, or what we now use dextrose. Also includes the umbrella of PRP or platelet-rich plasma, includes adipose tissue and bone marrow aspirate, along with other growth factors. So prolotherapy, how does it work? It works by injecting an irritating substance such as dextrose, like I mentioned, along with an anesthetic just for pain relief for the patients. And it creates a controlled, localized inflammation. And then we can also use other things like biologics. They can be a catalyst, so we activate the cellular metabolism and create natural healing. The whole purpose of these is to strengthen and regenerate damaged structures by proliferating cells, reducing pain, and improving movement and function. So there's expectations that come with this, including the healing times and expected recoveries. So the simple prolotherapy using dextrose solution is typically multiple courses spread up, approximately 4 to 6 courses spread amongst once a week for about 6 weeks. And then there are more intensive approaches such as adipose tissue and bone marrow aspirate. And these can be they're more aggressive options that can be done with 1 or 2 treatment courses spread over about 1 to 3 months. And all of that comes down to how well the patients respond to the treatments. Some patients respond better and they require less treatment. So that's prolotherapy. And then we come into platelet-rich plasma. It is effectively the patient's own blood, where we're concentrating healing factors. There's approximately 100 different growth factors that have been isolated that are found in PRP that are part of the healing process. With the main function of it being the platelets. There's a concentration of approximately 3 million platelets in the injection. So the process of it is that we take a patient's blood and we effectively concentrate it using a 2-spin system, where the first spin, we are just filtering out whole red blood cells. And with the second spin, we are concentrating with platelet-rich plasma, effectively creating the buffy coat layer. So there are ways to increase the efficacy of PRP. There's a number of different ways. The first way is low temperatures. There's photoactivation using low-level light, and that increases something called VEGF levels. And then there's other interleukins that are improved by this. There's also plasma dilution and tissue collagen. And these all create better activation in the tissue. So the applications for PRP are effectively very widespread. We can inject anywhere, musculoskeletal tendons, ligaments. We can help with sports injuries. We can help with arthritis. We can help with degenerative disorders, muscle tears, sprains, trigger points, a couple key things like meniscal tears of the knee, lateral medial epicondylitis. These are all studied cases where PRP has been effective. So PRP treatments are a little bit different than the prolotherapy treatments. They're typically performed about once a month. And some patients will require one treatment, some patients will require more than one. And the way we measure outcome is truly by restoration of function and improvement of pain. We talk about the patient's goals with them, and if we achieve their goals, we consider that a success. So the process of platelet proliferation, most of the growth factors that will be recruited with PRP are recruited to the area within 10 minutes, and the remaining 30% are proliferated over the 24 hours. That doesn't mean the healing is done. That's truly just the beginning. The growth factor healing curve of the body is a 7 to 10 day initial injury recovery, and then a 10 to 14 day healing process. So most patients don't notice any effects until after about 2 weeks. So there is an inflammatory aspect associated with platelet-rich plasma, and then a second inflammatory phase that lasts additional 7 to 10 days. So the most aggressive inflammation happens in the first 24 hours, and then the proliferation of inflammatory products happens over the next 7 to 10 days. So there are some factors of recovery from the treatment. There will be pain and soreness, and there can be swelling for the first few days. So what we typically suggest is heat application helps to improve blood flow, helps the body to bring in all the natural healing factors and to allow the body to recover. So we always recommend that patients resume normal activity, which isn't working out at the gym, but just activities of daily living as soon as they possibly can, once they can tolerate it through the soreness. And then we advise that patients do physical therapy for stretching, strengthening, range of motion, and stabilization of the tendons, ligaments, and muscles, typically about 4 to 5 days after the initial treatment. So now we get into adipose cell therapy. Adipose cell therapy, it's effectively a very small liposuction procedure where we remove a sample of adipose tissue and use it as a structural biologic for regeneration. So now we have to get into what are stem cells. So in 1987, Dr. Arnold Kaplan discovered MSCs, and he originally stated that stood for mesenchymal stem cells. And they're found primarily in high concentrations in adipose tissue, umbilical cord blood, amniotic fluid, dental pulp, and hair follicles. So while doing further research, he discovered that they don't meet the criteria of a true stem cell, but they're actually known as a medicinal signaling cell. So all the research shows that MSCs begin as pericytes, and they cause bioactive agents to release regenerative microenvironment for tissue regeneration. So this photo right here is the signaling pathway. These are all the things that MSCs are able to activate. One of the key functions on there is hematopoietic stem cell support. So this is the injury responsive pericytes and basically the function of what happens in the body. So there are particular characteristics that our MSCs are just characterized by. So they undergo homing to sites of inflammation, which means that the body directs them towards areas of injury. They're immunomodulatory, and they enhance things like exosomes, liposomes, and multilineage differentiating stress enduring cells. They're all pro-inflammatory, and they create antimicrobial abilities and release regulatory T cells to promote healing. So how does it work? Effectively, we do the liposomal procedure, and then we purify the adipose tissue to remove aliquots of blood and oil, and then we use a filtering process between two syringes that loosens the fibrous tissue without changing structure, effectively making it injectable. So what are human hematopoietic stem cells? So they exist in two areas in high concentrations, in bone marrow aspirate and in adipose. So they are what create our blood products, such as red and white blood cells, and they create our blood supply. These are the true drivers of tissue regeneration, and they differentiate into all human cells in the body, including MSCs. They have the effect of plasticity. And then along with that, there is a high concentration of interleukin-1 receptor antagonist proteins, also known as IRAP, and they also exist in high concentrations in the bone marrow. This is how the differentiation of HSCs happens, where they can effectively break down the cell lineages and create most cells of the body. So what the difference between the HSCs and the MSCs? So adipose tissue has more MSCs, while bone marrow has more, adipose has more HSCs, while bone marrow has more MSCs. And then the HSCs are more short-lived, while the MSCs are in higher concentration. And then we also have exosomes. An exosome is technically an extracorporeal membranous vesicle. They're released from cells when the multivesicular bodies fuse with the plasma membrane, and they create a role in cell-to-cell signaling, effectively intracellular communications, and they're protein carriers delivering growth factors. And then the final thing we come to is amniotic membrane components. These come from human amniotic membrane tissue, which effectively comes from amniotic sacs, and it contains growth factors, interleukins, and matrix metalloproteases and extracellular membranes. They do not contain true living cells. And then there are additional therapies: ozone therapy, IV vitamins, platelet-rich lysate, SVF, shockwave therapy, photomodulation. This list is just to say that the brief things that we covered today are not the complete story of what the field of regenerative medicine has to offer. It's just a brief introduction to it.
Beautiful. Nice job, Ben.
So I'll hand it over to Dr. Goddard now.
Hey, everyone. I'm Kristopher Goddard. Thanks for joining us, and thanks for having us here. Me and Ben here, we happen to be at an ultrasound for nerve course, and they, on a side note, they talked about hydrodissection of nerves with PRP, and the research kind of points to that it is a much better resolution long-term than traditional other hydrodissection therapies. So let's get into we're gonna get into some cases. Before I start with the cases, some things you have to think about with regenerative medicine are, how do we use it, right? We have to think, is the injury or pain, is it acute or chronic? How severe is it? Is it mild, moderate, severe? And then you have to know the product that you're using. And you have to know how it works, whether it be prolotherapy with dextrose or prolotherapy with PRP or bone marrow or adipose, or the amniotic matrix or exosome. So it's very important that you really understand what you're using, how you're using, and understanding what kind of injury you're dealing with. So let's go into our first case here. Okay, so This was a 56-year-old female. And as you can see, left chronic midfoot pain, had the deformity. She had tried PT, tried medication therapy, orthotics, all minimally helpful. She 100% wanted to avoid surgery. She loves to exercise, and obviously this kind of pain was keeping her from doing so. So I originally saw her back in 2019 for this, and she went to all the conservative treatment options, and then of course COVID happened, and then back in November of 21 she came back, and we started talking about whether she wanted to move forward and do treatments or go the surgical path, and she did go to specialists and be evaluated, and they preferred her to go the conservative path, but if surgery was necessary, and in her case, some of the specialists did recommend that, but she didn't want to do it. And the X-rays that we did showed no arthritis, but there was some soft tissue edema. But she also did not want to do an MRI, so we couldn't look at exactly what was going on. And because we didn't see any of the arthritic changes, I decided that PRP would be the best option for her, because I felt from a palpatory exam, she had a lot of ligament tenderness and a lot of tendon tenderness over many areas of her foot and ankle. And it was mild overall in my estimation. And of course, in her estimation, she couldn't work out like she wanted to. So it was more on the more severe realm. And as you can see, she was in constant pain. So here's the tenderness that we saw and what we saw on the X-rays, and very mild changes compared to what I normally see. So go ahead and go to the next one, Jesse. And so we decided to do PRP and go to the next one. And you can see, this is how I take the technique from prolotherapy, which is the idea of we're trying to stabilize the whole joint structure, whether it be an ankle, a foot, a knee, wherever it might be. And we're injecting almost all the time origin insertions of all these ligaments, and even the primary joint as well. And so go to the next one. And you can see the first few days, PRP in general creates extreme soreness, especially when you're doing it to inject ligaments. After 2 weeks, much better. She began moving into exercise with less pain, improved her range of motion. She was more active, and she was able to do much more aggressive activity without pain. And you can see at the bottom, this was 2 months post the procedure. And, you know, I talked to her maybe a month ago, and that was about 6 months. That was about 6 months afterward, and she's doing great at this point in time as well.
So we have a question. How do you know which agent to use, right? I mean, how do you know to use PRP versus, amniotic tissue or the HSCs or MSCs? Like, how do you figure that out?
Yeah, that's the tough part. That's what took me years and years to understand. So I started learning prolotherapy 18 years ago. And then it was on and off for about 9 years before I started doing it full time on my own. And for about 2 or 3 years, that's all I did. Then I got into PRP, and I did that for a couple of years. And then I got into the bone marrow and adipose and amniotic. And a lot of it is a clinical judgment decision as to what the best thing is. In general, if our patients, or if insurance would cover it, but if our patients can afford it, we prefer to do one of the, I say, quote, stem cell options, as Ben said, the terminology is moving to what we call medicinal signaling cell. But if we can do one of those, we're going to get a much better result than if out of one treatment than if we do PRP alone. But PRP works excellent for ligament and tendon issues. So I wish I could answer your question much more straightforward, but it is a judgment call and understanding over time of how each injury responds. With athletes, a lot of times we are more using something that is less inflammatory. PRP is very inflammatory, and so is bone marrow. And that can take, sometimes it can take 4 weeks just to recover from those procedures. So that's where the amniotic tissue or the exosomes comes into play, because they're very anti-inflammatory. And so people, especially athletes, they tend to recover, at least from a pain standpoint, in about a week. And then we have to build them up through therapy and to make sure they're strong enough and healed enough to get back on the field. All right. So our second case is a female, another middle-aged female, chronic left ankle pain. She was a volleyball player since high school and many years later. And her constant pain was 3 out of 10, with activity 7 out of 10. She couldn't run or jump. She had a severe instability, sharp pain, limited range of motion. And she had been dealing with this for many, many years by the time I saw her. And she was referred, she's actually a surgical scrub tech, and she was referred by a nurse practitioner that I treated as well. Go to the next one, Jesse. So you can see using topical Voltaren, multiple steroid shots. She had a unfortunate side effect that could unfortunately be with all of our injections. And as you can see, used to be very active. And at this point, she had been to many different specialists. And it was such frustrating for her that she was considering fusions or ankle replacement. And as you can see, only activity she could do was biking without pain. So initial exam, decreased range of motion everywhere, tenderness on every part of the ankle and most of the foot, except the common areas, which are plantar fascia, Achilles tendon, and inferior calcaneus. So the MRI showed full thickness cartilage loss at medial aspect, had evidence of sprains because the ligaments were thickened, and spur formation. And then, of course, as you can see, I don't have to read it all, but she had a lot of things going on within that ankle and the foot. So because this one was a lot more severe, and I like to work with the specialists, and if they're really leaning toward a surgery such as an ankle fusion, it makes me want to be more aggressive. So I hope this helps a little bit, at least today, in understanding how I think, because if it's getting to the degree that we think is extremely severe, it's a chronic issue because of the arthritic changes, the spurs, then I want to be more aggressive in my treatments. And the bone marrow was, in this case, we could have done the adipose or the bone marrow or the amniotic, but because of financial reasons, we chose the bone marrow. And so we went this direction instead of the PRP. And again, I used it and injected all the ligaments in the joint. And again, all these different areas, going into that prolotherapy technique and idea. Go ahead. And again, we went all over, everywhere. Yep. Even more so than on the lady we just talked about. And this lady, I like everybody getting to physical therapy. Not everybody does, but she was able to go 2 to 3 times a week. And the first few days, she was extremely sore. And one thing we have to watch out for in the inflammatory injections is they can get very swollen, and it can scare them a little bit. So this patient in particular sent me a picture a day after she was treated, and her foot looked like a big softball. And I've seen this many, many times because of how many injections I do and this type of product. And usually the more severe the injury, the more severe the swelling as well. But after a few days, it really came back down to normal. And then 2 weeks later, she was feeling better already. And she was already starting to see, by 1 month, improvements in range of motion. And even at work, she would be on her feet for 13 hours at a time and only need a few minutes of break, where before she almost had to take a break every 1 to 2 hours. And so she was able to get into be a little more aggressive activity without pain. And so 3 months, she had no pain on non-work days. And she still had some pain during work because she was on her feet 12 hours a day. But she did 6 weeks of PT, Range of motion is great. She's golfed back-to-back days with minimal pain, and she overall rates herself as 70% improved, both from a pain standpoint and from a functional standpoint. All right. Take it away, Jesse.
Thank you. Yeah, so I actually spoke with that lady recently, and she was very happy that she didn't have to have her ankle fused. She didn't have to have any surgery, and for the most part, she could pretty much do everything she wanted to do recently. I mean, and I think he injected her in November. So to give you an idea, it wasn't.
So guys, it's a quick question, because I do adipose stem cell injections, and it works really well. I've done it for knee, ankle, tendinopathies, but technique I've done is a little bit different than what you do, and I'm just wondering what your take is. I mean, I just injected in the joint for ankle arthritis, but you guys seem to take the time to actually inject insertions and origins. Do you feel like that's a big difference, especially with something like ankle arthritis, or is just putting it in the joint enough?
Sean, do you want to comment?
Here. Yeah. Sorry. Moved away for a sec. So the idea coming from a prolotherapy aspect or technique idea is that we want to stabilize the joint, and that's kind of, I guess, the whole philosophy is just a little different than just doing a joint injection. We look at it as the ligament laxity, even though you may not see a tear in there. We do believe there are micro tears and micro instability. And that micro instability can create friction enough to where we may not see the same results. And it could be that those ligaments are creating pain generators that are not present, that aren't just in the joint, obviously. So we feel like we're addressing those pain generators from the outside of the joint as well as going into the joint. But I've also injected adipose for all the ligaments too. And I see, to me, all the stem cell ideas are very similar. I've done them all, and I've seen great results with all of them. But I do almost always inject the ligaments with the joints.
Beautiful, thank you. All right, now we're going to go to an NFL player. So we treat a lot of NFL guys down here in Miami. Many of them train down here. Probably 50 to 100 to give you an idea every offseason or in the area. So many of them usually get their treatments in the offseason. These guys get ridiculously beat up. It's crazy. And we often, it's like, what's injured today? Like it literally, that's like, what do you want to address today? But a lot of them will just do everything at once. So this particular player we saw last year, 30-year-old male, and he had a really bad high ankle sprain. Thankfully he didn't need a tightrope. But you could probably, he suffered it. I want to say it was late October, early November. And they kept him out at least 6 weeks. I think he managed to play one final game of the season. And then we saw him 6 weeks later, and as you'll see in a sec, he was still hurting. He rehabbed with the team. He managed to come back. He did okay, but who knows what he had to take to be able to be functioning on the field. So we saw him 12 weeks after the injury, and he had pretty significant tenderness to palpation, about 6 inches above the syndesmosis, but, really along the entire syndesmosis. And then when we put ultrasound on him, and you'll see in a sec, I'll show you those images, he was really having difficulty with pain, with swelling, with cutting, which is obviously very important for a wide receiver, really most of the offensive players. And he really just couldn't do anything out of his breaks. He was very stagnant. He struggled with acceleration because that tissue just wasn't ready to do what he was asking to do, even though it had been a decent amount of time. So he gave it an appropriate amount of time, and he was still struggling. So he's like, all right, let's do something about it. So, when we threw the ultrasound on it, and he had pretty significant syndesmotic ligament tearing, the distal aspect was pretty thick. He had a decent size anechoic and hypoechoic areas A lot of the lateral ligaments were fine. He didn't have any other structural issues in that ankle or, that lower extremity, but that syndesmotic ligament was really, really beat up. And you can see this was, pretty standard for what I see. And most of the time, I was hoping he would be a lot better than this, but this just kind of gave me an idea why he was so in pain, still in pain. So he chose, and a lot of the pros end up choosing a non-inflammatory or less inflammatory stem cell product. He chose tissue allograft. And these guys are going to remember that they depend on their health. They depend on their body to be able to stay on the field. If you follow really any of the pros, you can see how much money they get paid. So it ends up being important that they can function in and out. And really, that's part of it. So they have a tendency to spend a little bit more than regular people because of how important it is for them to function at a really high level. So this was a pretty advanced procedure. We walked along the entire syndesmotic ligament. We walked distally. We didn't really put any in the joint. We didn't really need to. And that was what we'll call day one. By day two, he was already working with PT because these guys they don't stop. They want to go immediately. And they do a lot of grafts and they'll do dry needling. They are very aggressive and it's okay to be really aggressive really quickly. By day three, they have at the field, they have actually at the PT campus, they actually have a field. And he was already starting to run 2 or 3 days after the procedure, and he didn't really have much pain. Mind you, these guys have a higher threshold for pain, so you have to kind of take that into context. Day 4, he was already starting to cut again, which is kind of crazy, but we've seen it enough to know that this isn't a one-off. This is kind of just seems how it seems to be with a lot of these guys. And then by day 5, he was already 70% better. He had much better proprioception. The swelling was significantly less. He was able to suit up back-to-back days. And by a week out, he already had significant improvement. A couple weeks later, he's still going to have some discomfort, and that's, not surprising, obviously. But the fact that you can make something significantly better in 10 to 14 days with quote unquote just an injectable is pretty impressive. And we see this day in and day out. And a lot of these guys, their teams don't cover it. That's a separate discussion, but it is obviously available. They do get it. You may not know that they get it, but this is one of the reasons why a lot of these guys are able to sustain these crazy injuries, not have surgery, and still be able to kind of perform at a really high level on the field. In general, a little bit of a summary slide, moderate syndesmotic ligament sprain, 7 days, give or take, when he was already doing much better. And it really never bothered him again. We still see him regularly, and he doesn't really mention this injury ever. Obviously they have other ones, but at this point, this one didn't bother him, which is kind of impressive. A second case that will resonate with a lot of people is an avid runner. If you've ever told a runner not to run, it's like the worst thing you could possibly do. They just don't want to hear it. It's in their mind. It's what makes them feel normal. So they do not want to take time off. If they have to have a big surgery, they know that's going to really, really delay their return to running. So a 44-year-old male had pretty advanced plantar fasciitis. You'll see some ultrasounding in a minute. Regularly runs to 5 to 8 miles a day. Chronic right heel. He actually had it on both sides, but the right was much worse. He initially tried PRP, and he said initially it helped, and then it just came back with a vengeance, which unfortunately does happen because PRP sometimes just not strong enough for the level of injury that you're dealing with. He did shockwave therapy a couple times a week. He was willing to do anything to help to allow him to not be in pain while he's running. As you can see here on the ultrasounding, the posterior calcaneus looked fine. The plantar fascia was super thick. We compared it to his quote unquote good foot. And then that had a thickness of about, 0.22 millimeters. And then on the bad foot, depending on which angle you probe, we're looking at 0.44 centimeters. Or 0.40, depending on it. You can see that it was very thick, and this is directly where his pain was, no question. So, he's like, all right, I can't run. I need to do something about this. Even my work day, I can't, it's bothering me. You know, it hurts when I get off my chair. He's an office guy. So even that bothers him. So he was like, let's just do something about it. So he also chose tissue allograft because he didn't want to do bone marrow. And he also didn't want to do PRP again because he didn't have good luck with the first time. So you can see here his ultrasound technique, kind of hitting it. And a lot of the times we'll walk the needle through the scar tissue and you can hear it clear as day. It is really loud. It almost sounds like a needle going through styrofoam, if you kind of think of that, if you haven't done it before. And it obviously helps if you're doing it through ultrasound because you can actually see what you're looking at. A lot of this is scar tissue. So you're kind of breaking that back up with the needle after you hit it with lidocaine before you put in the product. Within 2 weeks, he was already, much better with the help of physical therapy. And then, within probably 2 weeks after that, he was already running daily. And then for the next 6 months, he ran pretty much every day without any pain in that specific area, which, is pretty impressive. So we did a 6-month follow-up and you could see that the area of injury initially was, 40 millimeters and 44, depending on the angle you took the probe at. 6 months out, it was about half as big still, which, he didn't have pain. He was still doing really great. I just wanted to get a gauge of, hey, where are you at? How is this doing? And he's kind of the type of person that wants to know this and be aggressive, proactively if they can. If you look at 9 months, which was, not too long ago, he started to get a little bit of the thickness back, but he was still not in pain. Obviously, if you have a runner that's running, he actually ran the Boston Marathon this year. So he's putting a lot of stress on this. And the fact that he can do that with, is still a third thicker than his quote unquote good side, but it's still in no pain. It was impressive. If you continue to trend it, it will probably get thicker again. The question is, will it bother him? And, I'm not sure. But the good news is he never had to have surgery and he was able to run pretty much without minimal downtime, to say the least. 2 weeks, everything. And he continues to do well without any issues with this specific thing. We did one thing of note is that with chronic plantar fascia, or really plantar fascia in general, we've noticed a high correlation or maybe a causation with calves. So as the gastrocs have a tendency to fire and get a little bit of micro tearing, if you don't address them, the plantar fascia never seems to really ever go away. If you feel anybody with plantar fasciitis and you palpate the back of their calf, they're probably going to be tender on that same side, especially where, it attaches behind the knee. And we've noticed that. So a lot of the times we will hit the back of the calf, especially where it inserts, look at it under ultrasound probe as well. We've seen a much better outcome if you do both areas as opposed to just the plantar fascia. And if there's no questions, we can finish strong with Ben.
Okay, thank you, Jesse. So,
And go ahead.
Dr. Parekh, what was that?
I said there's no questions from the crowd, so go ahead.
Okay, thank you. Go ahead, Ben.
So I'll be closing out the presentation with the final 2 cases. So unlike Dr. Morse's NFL player, these are just 2 very, very average people. So we'll be talking about them because unlike most of the patients that we deal with are just average people. So the first person his initials are BD. He's a 50-year-old male. So he presented with complaints of left knee weakness, instability, and decreased range of motion. And so his original issue was knee pain. And then on exam, we actually figured out a big part of his issue. But his history is that 2 years ago, he was skiing in Colorado when he caught the tip of his left ski while going downhill and wrenched his knee. And then while he was trying to stop, he felt a popping in his left knee. He went to see an orthopedic surgeon who told him he had an ACL tear and medial meniscus damage. He opted for ACL reconstruction using his quad tendon, which was performed approximately 4 weeks after the initial injury. And then while he was having his surgery, the surgeon found medial meniscus damage and removed the posterior horn of the medial meniscus. Ever since the surgery, though, the patient has not been the same. He is no longer able to use his knee to the extent that he would like. He is in constant pain and weakness. He has constant burning and numbness in his left knee. And then he's no longer able to run. And if he lands on his left knee, he's an excruciating 8 to 10 out of 10 pain. And then he describes the pain as frequent, dull, burning, sharp. He denies any numbness, tingling, or radiation. He had decreased range of motion. And it was worse when doing physical activity or running. He had tried things like acupuncture, heat, natural remedies, ice, physical therapy, and he really didn't have any improvement. But his biggest complaint was that he was an amateur bicyclist. He was trying to bicycle. His goal was about 100 miles per week. He found that he had no explosive force left in his leg. He couldn't push down on the pedal. So we got an MRI. He had a torn medial meniscus, showed fibrillation in the inner edge of the lateral meniscus, and had grade 2 arthritis throughout the knee. He had mild delamination of his PCL. The ACL graft was still intact. None of these issues should have prevented him from having explosive force on a bicycle. So we looked further, and I grabbed an ultrasound, and an ultrasound of his left Achilles showed a distal Achilles tear at the attachment to the calcaneus. And so I actually had him test jumping down from a height in the office. And what we kind of localized was that his pain was not actually in his knee. It was in his back of his foot and up into his calf. So what we did was diagnostic lidocaine into his Achilles and his calf attachments. And he was able to jump from a height of 3 feet down onto the floor without pain, which was the first time he'd been able to do that. So what that kind of showed us was that it wasn't actually his knee that was bothering him anymore. It's whatever he had at some point injured his Achilles, and to this point had been blaming it on his knee surgery. Jesse, can we go to the next slide? So the tissue he chose to do was, or the treatment he chose to do was tissue allograft. And we did injections on the Achilles insertion on his calcaneus and the Achilles aponeurosis. I used the technique called peppering to effectively inject all along the Achilles attachment on the calcaneus through multiple areas, and I used an ultrasound to guide it to the visualized area of tearing. Then we also did do some further injections in his knee joint space. We did his medial and lateral coronary ligaments, and then we did his hamstring and popliteus insertions. And then we also did his gastroc attachments. So his recovery was that for the first 2 days, he was very sore. But then on day 3, he gave me a call after he did this and said, I just went paddleboarding for about 3 hours and didn't have a lot of pain, which is very unlike me. He hadn't been able to do that for weeks and months prior to that. But he truly started to notice relief at 4 weeks. He had a significant improvement in activity. And nowadays, he's able to actually land on his left leg without pain. He's able to do aggressive activity without pain. And that was about 3 months. I spoke to him actually last week. This is a year post-treatment as he's preparing, as he's just a year, and we were discussing, and he told me that he is now able to bicycle. He does mountain bike racing out in Colorado, and he's doing 70 kilometers a day without pain, all because his Achilles recovered. Okay, so let's go to the next one. The next patient, his initials are KC, and he's a 47-year-old male. So this is a patient that he was referred to me by a physical therapist for chronic left chronic plantar pain. He had actually had the pain in both feet, but the left side bothered him significantly more. He'd had this issue for many years, just progressively worsening. It was made worse by running, especially on the beach. He said he loved running on the beach. It was something he hadn't been able to do over the last couple of years. He couldn't walk long distances. He'd have to sit down every quarter mile or so. He said he'd need to take a break. He couldn't ski anymore. And if he tried to stand up from a chair and walk suddenly and rapidly, he wasn't able to do it without pain. He really couldn't specify how many years ago it had started. He had a flare up a couple of years ago that lasted 3 to 4 months and then went away with not much. But lately, over the last couple months prior to this, he had started having flare-ups again. He's still unable to ski, and he can't run. He actually gave up on doing both of those just due to the pain. He wanted to avoid surgery, and he wanted to keep playing his golf. He tries to play golf 3 days a week, and he just hasn't been able to do that. He tried physical therapy. The physical therapist that referred him to me said that he was with her for 4 months prior to being referred to me. He had minimal help, and it was just progressively worsening. So we did an ultrasound, and it showed chronic degenerative changes in both plantar fascia along with bone spurring in the left calcaneus. There was a hypocholic area of the plantar fascia in the left foot at the attachment to the calcaneus. It was nearly confirmatory of a tear in the plantar fascia. He also chose to do tissue allograft. And so I used the same technique as the prior patient, the peppering. It's effectively the earliest prolotherapy technique, is peppering throughout the tissue, all the attachments to the bone. I use an ultrasound to guide the injection to the area of tear. And then typically once I do that, I will remove the ultrasound and pepper throughout the bony attachments. This is now a patient. The first few days, he could not bear weight. He couldn't stand up. He couldn't walk. After about a week, he started having much less pain. He started being able to exercise again. After about 2 months, he started able to stand up and walk without pain, which is not something he was able to do. After about 3 to 4 months, he was now playing golf 4 to 5 times per week without pain. And he's playing a full 18 holes of golf. So he's noticed significant improvement in the muscle. The physical therapist always mentioned that he had extreme hypertonicity in his calf in that leg. About 3 months after the injections, that hypertonicity disappeared. He actually just finished the 4-week ski season in Vail a couple weeks ago. Last year, he was able to ski for maybe 1 to 2 hours a day without pain. And this year, he was doing 4 days a week of 8-hour days with no pain in his foot. Okay, and that's all I've got. Thank you all very much.
Beautiful.
Awesome. We do not have any questions that have come through. That's great. You know, again, regenerative medicine, I know for you guys, has been around for a long time, but from a surgical application perspective, most of the time it's not covered by insurance. And really, it's just starting to find its way into clinical practice. And for most people, it's not even in clinical practice yet. But I think that that's the way this whole industry is moving towards. And I think it's something that at the very least we should be knowledgeable about as surgeons, so that even if it's not a service we offer, we know where to send patients so that they can get the treatments that they may want or need, especially if they don't want surgery. So I appreciate you guys going into this with us and showing us some case examples. And Jesse, thanks for moderating. And with that, we made it to 24 hours. Thanks everybody for joining us. This is going to be something that we do every year. So next March, we'll be doing this again. It'll be a different theme. And so stay tuned to it. The entire 24 hours was recorded, and will be uploaded to my YouTube channel in about 6 weeks. So you'll be able to get notifications on that, and I'll send an email out to all of you who have registered so that you get it through your emails. But other than that, feel free to subscribe to the YouTube channel if you want. That way it'll ping you when it's all uploaded as well. But with that, we'll close out. Thanks again, and have a great weekend.